And good evening, ladies and gentlemen. I'm Pallavi, and I welcome all of you to the second episode of HSI Prime Time. I'd start by thanking Dr. Bittner for accepting our invite and agreeing to speak in this program, and Dr. Chaube sir for graciously agreeing to host the program. It's an absolute honor to have the two legends of surgery on the screen together and having the privilege of learning from them. In this program, we are going to have a 30 minutes lecture by Dr. Bittner, followed by an interactive conversation between Dr. Bittner and Dr. Chaube. Before we start, I'll say a little bit about Hernia Society of India. I think most of our audience is already aware. For those who are not, Hernia Society of India is the national chapter of Asia Pacific Hernia Society, and we are very active academically. In this academic year, we have had over 20 high value virtual academic programs, including a 3-day virtual live conference. HSI Prime Time is the most recent addition to our academic programs, designed by our to innovation. What does it take to reach where they have reached, and what are the challenges that they have faced in the process? Today, we'll have the conversation on the extraperitoneal repair of ventral hernias. They are the hot new kids on the block in the hernia surgery town, and it's only fitting to be able to hear about it from a man who's seen it all and done it all. You are all going to love today's session. And with that, I'd hand over the screen to Dr. S.P. Sarkar to introduce our legends of today's episode. Dr. Sarkar, the screen is all yours.
Thank you. Thanks, Pallavi. And thanks to our honorary president, Dr. Ramesh Agarwala, HSI, for allowing me to have this privilege to introduce Dr. Bittner and Dr. Pradeep Chaube. I start with Dr. Bittner. Reinhard Bittner, MD, FRCS, FICLS, is a recognized leader in the fields of minimum invasive surgery. He was trained in general and vascular surgery in the University Hospitals of Berlin, LSM in the upper GI tract, colorectal, and pancreatic surgery. After his university career, he served for nearly 20 years as director and professor of surgery of the Department of General and Visceral Surgery at Marian Hospital, Stuttgart, teaching hospital of the Medical University of Tübingen. During this time, under his leadership, more than 60,000 patients, more than 16,000 laparoscopic inguinal hernia repairs in TAP technique, 9,000 laparoscopic cholecystectomies, more than 1,500 laparoscopic colorectal resections were operated on about 20,000 by himself, mainly in minimally invasive technique during the last 15 years. Already in early 90s, he recognized the advent of minimal invasive surgery as an important step to the development of more patient-friendly surgery. Therefore, he focused more and more on these new techniques. Especially, he concentrated on the transabdominal preperitoneal patchplasty, TAPP, in inguinal hernia repair. From the beginning, all patients' data were recorded and analyzed, inclusive a careful done follow-up. Interestingly, TAP was standardized and popularized with the result that this new technique could routinely performed by all surgeons in his hospital and by all surgeons willing to learn outside his hospital. He organized countless workshops and prospective studies as well as consensus conferences, published the data in leading journals, and was mainly involved in the development of guidelines in hernia surgery. 3 edited books related to hernia surgery and written by international team of experts of hernia surgery completed his work dedicated to the hernia repair. Not at least due to his leadership, more than 60% of hernia repairs in Germany are currently done in laparoscopic technique. 40% of them are TAP. During the last year, he developed and published a new minimal invasive technique, endoscopic minimal oblique less open sublay for repair of ventral and incisional hernias combined with the rectus diastasis. This technique allows the implantation of the large meshes 20 into 30 or 40 centimeter in the retromuscular space via skin incision not wider than 5 centimeter and avoiding the access through the abdominal cavity. He was the founding president of German Association of Minimal Invasive Surgery and organized innumerable educational meetings and live surgery demonstration in minimally invasive surgery. Furthermore, he was founding member of the German Hernia Society and vice president of this society for 10 years. Currently, he is honorary president of the society. He has published more than 350 original papers, 6 randomized control studies, RCTs, 2 systemic reviews, 5 guidelines, and has given a countless number of scientific lectures, not only in Germany, but also around the world, in total 38 countries outside Germany. His impact factor reaches 480. He did live surgery in laparoscopic hernia repair, but also in cholecystectomy and the colonic resection in about 60 institutions in more than 23 countries in Europe, America, Africa, and Asia. For 8 years, he was member of board of directors of German Society of Surgery, president of German Society of General and Visceral Surgery in 2005 and 6. He received the Doctor Honoris Causa, Dr. AC from University of Yangzhou, China, and University of Vilnius, Lithuania, one of the oldest in Europe. Moreover, he was honored with the honorary membership of the Society of Minimally Invasive Surgery, Lithuania, the Asia Pacific Hernia Society, Indian Association of Gastrointestinal Endosurgeons, and Indonesian Society of Endolaparoscopic Surgeons. He was honored with the title Fellow of Royal College of Surgery, England, FRCS, and the Fellowship of the International College of Laparoscopic Surgeons, FICLS. In 2008, he received the Rudolf Pichi-Mayer Medal, the highest award for German Society of General and Visceral Surgery. In 2010, he received the Knight Cross given by the President of Germany. Since 2015, he serves as subject editor of the Journal of Surgical Endoscopy for the section Hernia and the HPV surgery. Since 2018, he serves as European editor-in-chief of the International Journal of Abdominal Wall and Hernia Surgery. Between 2019 and 20, he worked as full professor of Sekhnov University in Moscow, Russia. In summary, Reinhard Bittner is a tireless worker for many years, serving the German Hernia Society as an auditor for the acknowledgement of German Hernia Center to improve outcome, and the surgeons as subject editor of the prestigious Journal of the Surgical Endoscopy to improve the science in hernia treatment. He and his wife, Ute, are living in Stuttgart, Germany, and are proud parents of the 3 grown children and 10 grandchildren. In his scarce free time, he likes to read, to visit museums, especially for painting, to discuss political affairs and football with his children, and traveling and cooking and gardening with his wife. That's Dr. Bittner presented proudly on behalf of Hernia Society of India. Now, I know for this our gathering, we need no introduction for Dr. Pradeep Chaube, who is the mentor of Hernia Society of India. That's the APHS, is the Indian Association of Gastrointestinal Endosurgeons. Professor Dr. Chaube is the man, is the leader who actually inspired all of us and took the minimally invasive surgery to every corner of India. We can talk half an hour about him, but he is the teacher of teachers, and he took all of us, inspired all of us to take the minimal invasive surgery to the poorest of the poor and all corners of India. I feel the 2 giants meet, and we are the very inquisitive learners and students. Thank you, sir. I request Dr. Bittner to start his presentation.
Yeah, thank you very much. First of all, many thanks for this very kind introduction. I personally, I'm being impressed about all what you talked about me, and still, I remain a very simple human being, and this is I'm especially proud of. So it is a great honor to speak here about my last project, and with special happy to see my very old friend Pradeep Chaubey here. And I think it's about 20 years we are working together and met each other around the world. And always it was a great event, a great pleasure to see you in Delhi and to talk with you and to learn something about your great country. So once again, many thanks. And to Dr. Agarwala, many thanks for this invitation, and also for Professor Desalkar for the introduction. And so I'm very proud of. So best greetings from Stuttgart. And you know, we are producing Porsche and Mercedes cars and a lot of other things. But my topic today, as I told you, my last, I think it will be my last project, that is abdominal wall hernia with endoscopic knee. And allow to talk some historical remarks. I started my education in 1970 in Berlin. And look, at that time, it was a big hospital taking care for more than 300,000 people of Berlin. We had only 20 to 30 operations because of abdominal wall hernias per year, only 20 to 30. And this was the same when I accompanied Professor Beger, who get the share in University Hospital of Ulm. Surgery of abdominal wall hernias at that time didn't play any significant role. And this changed dramatically when I became a chief surgeon in Stuttgart in 1990. You can see gradually an increase of these hernia operations, so nearly 300 because of abdominal wall hernias we did per year at that time, at my active time. So the reason for this dramatic increase, you see, I listed 6 reasons. It is, of course, it's modern surgery with less restrictions, especially to aged patients, and also the radical operations because of peritonitis with open abdomen and laparoscopy. So a lot of reasons responsible for this dramatic increase of surgery of the abdominal wall. And so currently we have in Germany about 50,000 hernias because of primary and secondary abdominal wall hernias, and in the US more than 200,000, and I think in India it will be 600,000 operations per year. So these operations are not only important for the individual patient, but because of this huge number. And most of these patients are not so aged, so they are in the middle of their or at the end of their work. So you can imagine that this is also a huge economic factor for the healthcare system. And this situation, this dramatic increase is reflected also in the scientific literature. My research in PubMed for the publications with the term incisional hernia, before invention of the laparoscopic technique by Carl Leblanc in 1993, we had no more than 100 publications in a 5-year interval, and currently it is more than 1,500 publications you can find in PubMed with the term incisional hernia. So a huge impact on research. So I want to discuss 4 points with you. First question is, should we use a mesh, or is suture repair sufficient? Then second question, which is the best position of the mesh within the different layers of the abdominal wall? Then third question, how to bring the mesh in the best position? And last question, should we use a hybrid technique, an open technique, or a pure endoscopic technique? First question, mesh or no mesh? And you can see already in 2005, we published our data from the early years in Stuttgart. The early years, we repaired abdominal wall hernias, and we could compare suture repair as we did in the beginning of the 90s. Then we changed to mesh repair in the middle and the end of the 90s. And you can see in this analysis, when we had the mesh repair, after 5 years, we had only 5% recurrences. Suture repair, 18% recurrences. And it is interesting that in a recent study, we had just the same results. With mesh repair, around 7% recurrence rate, and with suture repair, nearly 24% recurrence rate. So the first question, very clear to answer. The use of mesh reduces significantly the recurrence rate. Second question, what is the best position? And you can see we have about 5 positions shown in these schemas. And so what is the best? Should we do an inlay bridging, and should we do onlay, sublay, or should we do lap IPOM? Or as Flamand already in 2001 propagated, should we use a pre-peritoneal position? So recent literature, recent research shows that the best position, like Reeves propagated in 1973, and Hollin concluded that placing mesh in the sublay position, as opposed to the onlay or underlay position, may decrease the risk of hernia recurrence and the risk of surgical site infections. So the answer seems to be quite clear. The sublay or retromuscular position seems to be the best position. Now the third question, how to bring the mesh in this best position? By open technique, we have well-known disadvantages: big trauma to the abdominal wall, seroma production, infection, and pain. So now the question is the IPOM technique, the solution. But IPOM technique has also disadvantages. The risk for bowel injury, the risk for adhesions and later on ileus formations, and high costs. The special mesh, the tucks are costly. And that is important regarding pain. There is no significant difference between open supply and the IPOM technique. So, what is the answer? We can say that up to now, there's insufficient evidence to answer this question. However, laparoscopic approach reduces surgical site complication. That is quite clear. There's no question. But the costs are significantly higher, as I mentioned. So is the Milos concept the solution? The Milos concept was developed by Wolfgang Reinpold. Can this concept overcome the disadvantages of these two techniques, the transabdominal route, the IPOM, or the open mesh placement? Milos concept means mini or less open supply. Small skin incision, we can implant a very large mesh, a very simple mesh, must not be covered, sheep mesh. We can bring it in the retromuscular position without entering the abdominal cavity. It needs no fixation. And in summary, it's a low-cost procedure. We, Wolfgang Reinpold and our team, we could publish the results in Annals of Surgery in 2019. With the propensity score, we could compare about 600 patients with the IPOM technique or the open supply technique with the help of the data of our hernia made registry. And the result was, with the Milos technique, we saw less complications, less recurrences, and less chronic pain. So, some remarks about the Milos technique. We have a small skin incision, then we just in front of the hernia sac or the hernia defect. Then the hernia sac is dissected and the hernia ring is exposed. The hernia ring will be elevated with the sharp clamps. And then the hernia sac will be pushed down and also the preperitoneal fat so that the posterior rectus sheath can be exposed. Then the next is the incision of the posterior rectus sheath about 1 to 2 centimeter laterally of the linea alba. As you can see here, we have the anterior sheet of the anterior sheet of the rectus sheath, and here the posterior, that is the rectus muscle, the back wall. And then if we have this opening, then the posterior rectus sheath is incised bilaterally, upwards in direction to the xiphoid and downwards in direction to the symphysis. And Wolfgang Reinpold used special long instruments and a special developed light source. And this is important. The linea alba has to be strictly preserved. So incision continued here, incision continued there, and the same on the other side. So we we visited Dr. Reimpold in Hamburg, and then we, with my co-worker Jochen Schwarz, we tried to reproduce this technique in Rottenburg, where I was busy during the last 4 years. And then we saw that it's very difficult to do a very good dissection, the more the distance between the small skin incision and the needed dissection area far from this incision is, the more difficult the operation. As I mentioned before, special instrument and the special light source is needed. You can make the comparison. You are standing just in front of a cave, on the entrance of a cave, and you should dissect very far from this entrance. You should do something in the at the end of this cave. So we had the idea: why shouldn't we do this endoscopically? So and then we developed step by step the Emilus operation. The Emilus operation. Emilus operation means we do just in the beginning the same like the Milos, but then we close the skin and continue with endoscopic surgery. So when we started in 2016 with this technique, I'd say variation 1. That was that we introduced, like in the TEP, what I so many times saw with my great friend Pradeep Chobi. We introduced a balloon, and in the beginning we used the balloon. Pradeep published, I think, about 20 years ago. We used a finger glove balloon to save cost. No, I worked in a small hospital and not very rich, so we had to calculate with every euro. So we did Pradeep's technique with this finger glove balloon and introduced this two-direction suprapubic area, as you can see on the right slide here. So then we dilated this region, and then we introduced suprapubic. We introduced the optic trocar, and then of course after retraction of this dilation balloon, then of course we introduced first from here the optic with gas, and then we introduced here suprapubic, the definite optic trocar for further operation. Then we closed the skin and continued. As you can see here, we closed in the position the first optic trocar, and then we started with the endoscopic operation with the help of two walking trocar, 5 millimeter, right side, left side. That is easy. Here, the hernia defect. You can see the hernia defect. This is this trocar on inside, so you can see from outside. And we had here several needles to mark the region we had dissected. And this dissection is as you can see, is very easy. We have the rectus muscle. We have the preperitoneal fat. We have the rectus sheath. That's the right side. rectus muscle, rectus sheath, linea alba here, linea alba. And the linea alba must be preserved. So the incision is just about 1 centimeter lateral to the linea alba. Here's the posterior rectus sheath, linea alba. Here's the rectus muscle. And step by step, you can use this scissor, but you can also use an electro hook. It's very nice with electro hook. And linea alba, then pushing down the preperitoneal fat, not open the abdominal cavity. And step by step, you will approach from the umbilical region, you will approach the xiphoid, rectus muscle. Then again, the rectus sheath, the posterior rectus sheath, the left side. And it is very nicely, as I can show you just in some seconds, you can identify the neurovascular bundles and you can preserve, of course. So no injury, no danger for the neurovascular supply of the rectus muscle and the other muscles of the abdominal wall. So it's very, as you can see, all these operations I assisted to Dr. Schwarz because in my age and so on, I wanted that the technique will be learned by a younger one and continued. Yes, one of the rectomuscular, neuromuscular bundle. And you can see it's wonderful. It's very easy to dissect this. Very easy. And here, the xiphoid. Here you can see the xiphoid. So you must go below the xiphoid to push the mesh within the so-called fatty triangle. Now there was a needle from outside to show where we are working. Tucker, needle, rectus muscle, the costal margin, xiphoid, again lateral, xiphoid, posterior rectus sheath, needle here for marking, needle here. You can see then from outside the position. And then for dissection of the suprapubic region, we introduce an optic trocar here and then dissect needle. Then we can very clearly dissect the suprapubic region. We can enter the space of retios here from outside, the needles marking this huge region, the complete retromuscular region from xiphoid to suprapubic region. And you can easily repair an combined, when we push the mesh, the combined inguinal hernia, for example, and we track the mesh, it's a double roll. We introduce the mesh through this suprapubic optic trocar, 12 millimeter. And then we in the beginning, we had a lot of stay sutures and for better placement. For the placement of the mesh, it's very important to have the right side. Normally, in length, it's about 30 centimeter, but in the width, it could be only 14 or 15 centimeter. And correspondingly, it is difficult to spread very plain this mesh. If you have a too large mesh, then it will be difficult to place it without any faults. And here again, the section, the linea alba, the costal margin, the xiphoid, and down here, the preperitoneal fat with the peritoneum. You can enter easily, you can enter the mediastinum here. So if necessary, if you have a big hernia in this region, then you can place very easily the mesh behind the sternum. Linea alba is preserved. That's very important. If you have a big rectus diastasis, of course, then you can suture the rectus, the linea alba, the defect here, the hernia defect, the working TOCA. And when we started this technique, we didn't care to suture the posterior wall of the rectus sheath. We left it open, but some patients developed an bulging. They had no recurrence, but they had a bulging. So then we started, after the first 25 cases, to suture the posterior rectus sheath. This, of course, that is not possible just in the region of the xiphoid, and this is a region of the fatty triangle, and anyway, it must be left open for placement of the mesh behind the xiphoid. So, but then down here, it is not so difficult to suture. But it's important. To have a complete dissection of the retromuscular region. And you see here the neurovascular bundle. You must preserve. And if you want, if you have tension, then you can continue with the TAR procedure. As I demonstrated here, you can open the posterior rectus sheath and then continue to a TAR procedure. So that was our first approach. Then we learned that it's not necessary to have this with the dilation balloon and so on. We learned, I have to agree with Belyansky and the ETAP technique. So then we changed to variation 2. That means we dissect all what I told you here, but then we introduce the first optic TOCA below the xiphoid. It is very easy. From this, you can go with your finger and introduce this optic TOCA with finger guiding. So it's much more faster than to do here with balloon and so on and so on. So that is our currently used or recommended variation of this technique. And you can see that this was not a too small hernia. And this patient, we had this mesh size 20 by 30 centimeter. So best indication for this technique is a combination of an epigastric or umbilical or incisional hernia, a combination with, I say, an unstable abdominal wall. That means in combination with significant rectus diastasis. The reason for this, you can say huge dissection area implantation of the huge mesh, despite relative small hernias, is that Köhler published that if we neglect this rectus diastasis, so in my words, unstable abdominal wall, then we will have a high recurrence rate. If we do a suture repair, even in small hernias, or implant only a small mesh, not recognizing the unstable abdominal wall. So we could publish in 2017, and I think we were the first to publish a reliable, a standardizable endoscopic technique for repair of these hernias. So the advantages compared to the minors is we do not need special instruments, and that I must emphasize that this endoscopic dissection, I think all of you made this experience. The endoscopic dissection is essentially easier than the open dissection because we have the help of the gas pressure, and we can do it with very fine instruments, endoscopic instruments. So in summary, this technique is much more easier than to perform than an open dissection or the minus section. And you can see this is the patients day 1, day 3. I mean, they have astonishing less pain after 1 year. Nearly no scar is to see. So in total, we up to now we overlook 173 patients, and as expected, most 120 were umbilical epigastric hernias and rectus diastasis, but also 53 with an incisional hernia. BMI, 30, as I think everywhere these patients are overweight. And you can see here that is a patient, he had twice an IPOM. Nevertheless, he became a recurrence because of this unstable abdominal wall. And this patient, it was in front of the IPOM mesh, was quite easy. This is a point we can discuss. 160 minutes, the mean operative time in these patients, 160 minutes. But we analyzed the individual times and saw that after 20 to 25 operations, this time could be decreased to about 120 only. Defect size, as I mentioned, not very impressive, 19 square centimeter. But on average, all these patients had a rectus diastasis size width 5 centimeter, and huge mesh. So standard mesh, more in just 44, 30 centimeter in length, width between 15 and 24 centimeter. And you can see this is really measured the length of the incision, 4.6 centimeter. Hospital stay, 4.8 days. Complications, very, very low. Only we had 2 revisions, so 1.4% revision, about 1.4, and up to now, only 1 recurrence. So we planned a systematic follow-up for the last year, but due to the pandemic, we couldn't do this. But we will at least we'll start with telephone call, and with after this pandemic, we will do clinical follow-up of these patients. But it's, I think, impressive results, and I want to emphasize really very less pain. So coming to the conclusion for this part, best indication, as I mentioned, small, middle-sized primary, secondary ventral hernias with a concomitant rectus diastasis. Complete standardizable, complication rate low, despite this routinely large mesh implantation, learning curve about 20 to 30 cases, and cost effective because we have no special mesh, no fixation. My last question, hybrid. The EMILOS is a hybrid technique. Or should we do a pure endoscopically technique like the ETP? ETP technique was invented by Jorge for the inguinal hernia primary, and then von Bilyansky applied to the ventral hernias, but they published their data 1 year after our publication. So hybrid, you see, what is better, the original, or this hybrid? The newer pure endoscopic I mentioned Bilyansky in 2018, the enhanced view totally extraperitoneal patch technique. Then from my Chinese friends, Li Bigin, we had last year published the totally endoscopic sublet technique and the totally extraperitoneal approach for repair of ventral hernias. Very short. This is a publication and some pictures published by Bilyansky. Disadvantage of this technique, the section of large hernia sacs may be more difficult than in open. Then the entering of the contralateral side may be difficult, especially in incisional hernias. And so if we have a lot of scar tissue, then it may also be difficult and time consuming. So the operation time published by Bilyansky is much more longer than we had, but on the other hand, they had also more difficult cases. So advantage, no large skin incision and no opening of the abdominal cavity. This is a total endoscopic sublet technique, which we published last year, took up position that is very similar to the endoscopic part of the EMILOS technique, and then also a picture of the section of the hernia sac, and also the same, you can see here the suture of the posterior rectus sheath, so very similar. All the endoscopic part of all these techniques is just the same. The same disadvantages like in the ETP technique, advantage the same. Then that is a very interesting approach, but not applicable for a lot of patients. That is the suprapubic down top dissection with placement of the mesh preperitoneal. So no incision of the posterior rectus sheath, but the dissection area is between rectus sheath and the peritoneum, respectively the periperitoneum fact. So beginning is like in the endoscopic supply approach, but then exposition of the arcuate line, but not incision of the arcuate line, but going down inferior to the arcuate line and dissection of the preperitoneal region. That is because of the peritoneum in many patients is very, very slim. It's very we have to be very, very careful not to make holes in an opening of the abdominal cavity. So especially in incision hernia, this technique is not applicable. It's only in primary hernias. So the advantages is quite clear. No large skin incision, no opening of the abdominal cavity, and no cutting of any structures of the abdominal wall. So in summary, the hybrid technique, in my opinion, advantage, rapid dissection of the hernia sub. Then we can, after we position the mesh and we reopen, then the provisionally skin closure, we reopening for defect closure, and then we can control, we can do a lavage of the retromuscular region, and we can control the position of the mesh with a finger. Then that is quite clear, easy and safe defect closure. Disadvantage, we have a skin incision. So the totally endoscopic, no skin incision, but difficult approach to the retromuscular plane of the contralateral side, more difficult reduction of the hernia sac, and maybe difficult defect closure. But anyway, there's an urgent need for randomized controlled studies. Some kind of therapeutic algorithm I could recommend: Milos open in small, middle-sized primary and secondary hernia in the midline of a stable abdominal wall. So not needing implantation of a huge mesh. The hybrid, small, middle-sized primary and secondary hernias in the midline of an unstable abdominal wall. So in combination with his rectus diastasis, so we should implant a very large mesh. Totally endoscopic, we can repair small, middle size. Also, if you have some very good skills, also large primary and secondary hernias in the midline of the abdominal wall. So to learn more, read the guidelines, part B. The new techniques are discussed, published in 2019. So, dear friends, ladies and gentlemen, I thank you very much for your attention, and I hope not to be too long with my lecture. Thank you very much. Thank you.
Thank you so much, Dr. Bittner. I think I speak for everyone when I say that the talk was not too long. It was actually so engaging that we lost track of all time. It was especially useful to know all the variations of Milos technique, especially for those of us who are just starting to venture into totally extraperitoneal space and Milos technique. I wouldn't take a lot of your time. I think I would hand over the stage to Dr. Chaubey sir and Dr. Bittner for a candid talk. And there are a few questions, but I think Dr. Bittner has already addressed them in his talk. We'd go ahead with the conversation as we earlier planned, and as and when a question comes, I'd forward those post in the chat box here and on the personal WhatsApp of Dr. Chopper, sir. Sir?
Yeah, thank you, Priya, for conducting this so effectively. And Reinhard, I think for all these 2 decades, I think I have listened to you so many times, but every time there is something new, you have got some good ideas, innovative ideas. And I will also say that I have been following at the very beginning of my laws and technique, and we have discussed it on numerous occasions. I very strongly advocate and full-heartedly agree with Reinhard the way forward for abdominal wall hernia. I have always maintained, I'm sure our colleagues know my approach, that we have to understand that hernia is a benign condition and the surgery cannot be too extensive or too destructive, but it has to be the balance. And for most of the hernias in groin, etc., we know that laparoscopy is the final answer. But in the situations which have just been elaborated and mentioned by Reinhard, that is the way the modification should go. And I feel that this is the way forward. And congratulations, Reinhard, for promoting it so well and also demonstrating the technique. What I would, for others, what I would like to emphasize that the way Reinhard had described that the midline linea alba is sacrosanct. And that is what I would, you cannot just cut the linea alba and, suture the linea alba again. I think, Reinhard, I would like to take one big message, and I would like to let everybody know that midline and linea alba is sacrosanct, and we should keep the integrity of linea alba. By dividing it and resuturing it doesn't make any sense to me, at least with a limited understanding of the abdominal wall. Reinhard, what I feel is that, what do you think is the numbers which you have shown that in 70s, the number of hernia surgeries were very less and over a period of time? What do you think is your interpretation about that? Why do you think that at that time the surgeries, do you think the abdominal wall surgeries in totality were less and hence the hernia were less?
Yeah, that is a very good question. I thought of very often, but the last point I listed was expectations of the patients. At that time, if the patient had a bulge in the midline, he didn't care a lot of. He didn't care of. Or he was operated, let's say stomach or colon, and developed also a bulge. So, okay, he said, or had pain, okay, I was operated. So that's quite normal. I have a bulge. And they came not before some incarceration or so happened. So now the expectations of the patients, at least in our country and I think also around the world, is you want to have a perfect body. No scar, no pain, no bulge. And so the patients go earlier to the doctor, not when it is in sometimes it was too late with huge bite. So I think this is one point, and the other is of course modern surgery, vascular surgery, especially with this aneurysm surgery. With we know these patients have a very weak weak tissue,
Collagen.
connective tissue, and develop much more hernias. At that time, we had, for example, for total gastrectomy, we had 50 years. That was age limit. So today we have all age groups. So that's another, I think, with increasingly weak connective tissue.
Do you think you will contribute the more liberal, more frequent cesarean sections also for responsible for these hernias, abdominal wall hernias?
Very rare in Germany. Very, very rare.
Yeah.
Suprapubic hernias are very, very rare, following cesarean sections. Very, very, very rare in Germany.
Yeah, but then you're talking of the transverse incisions. But sometimes the less experienced gynecologist in the smaller places might like to give. At that time, I'm not talking now, but I think they might have been giving more vertical paramedial or incisions. Second point, I would have expected it more, because at that time, I think all of us, we were using chromic catgut and plain catgut, and that was the only thing available to us for closing the abdomen. So one would expect more chances of herniation. So that is one point. Another point which I feel now, which you may find it a little funny also, but do you think now the abdominal wall, the period of abdominal wall hernia is over? Because for last 30 years, we are doing all laparoscopic surgery. So most of the abdominal interventions are laparoscopic, and thanks to persistent push from person like you, who will literally get agitated if somebody talks about the conventional, say, hernia surgery. At least for groin, I've seen you really are very passionate about endoscopic. And if I'm not exaggerating, I think, Reinhard, you are one person, you fought the battle with the great warriors just to promote and to emphasize that laparoscopic surgery and endoscopic surgery is the future of at least hernia surgery. I know that you have got a lot of interest in colon, but you are known more for hernia, and that we are talking about it. So this is what I feel, that in future, do you think there will be less abdominal wall hernia because of this laparoscopic revolution?
Yeah, that is a very, very good prognosis. Yeah, I think I can agree. I can agree. We will see. We will see. We have the problem with trocar hernias, so some points are to respect also in endoscopic surgery. We can discuss, especially to minimize the instruments, and also look that the position of the trocars is not too lateral, not in the weak parts of the abdominal wall. It's, I think these points are, especially in you do a lot of obesity surgery, especially in these patients. We have a lot of cases with trocar hernias. So that is a point we have to work on, to improve the instruments and also to define the positions where best position not to develop trocar hernias later on. But okay, this is some melody of future. For this time, I think we should take more care to close the abdominal wall in the best way. In former times, it was the big surgeon did the intra-abdominal operation, and then he left, and the youth could close. In my opinion, as you build your bed, then you will rest. So if you open, the opening is very important. You mentioned the linea alba. I appreciate very, very much. I appreciate. So you have to be very careful to open in the middle of the linea alba, and then do small bite technique with long absorbable or not absorbable, better not absorbable suture, and very careful suture the fascia, not the muscle, with big bites. And that is the point. I can, from my personal, you have the data where in my introduction I did so many abdominal wall surgery, but I can confess the rate of incisional hernias were not so high, because it was my always precise opening in the midline, and then very careful suture the fascia, not taking big bites with the muscle, because then you will have necrosis, and that the suture will not hold any longer, and so on and so on. So this is also a very, very important point.
And also, I would like to add that I think all the ports which are more than 5 millimeter, I think they should be closed methodically and systematically without any doubt. And again, for our youngsters, I would say that please try to make bigger ports above the umbilicus, level of umbilicus, I would say, above the level of umbilicus, and medial to the mid-clavicular line, because these are the strong areas where port herniation is not, or maybe less chances of herniation. So that is another point. I will appreciate my other senior colleagues if they have any questions. Please go ahead. Ramesh?
Yes. So I don't think we could have asked for something more. Two stalwarts of hernia surgery in the world scene together sharing this time. And I can speak on behalf of all the Indian audience that Professor Bittner, we are really privileged and proud, and Professor Chobe, to have both of you all together on this Saturday evening. And we have all learned so much from your knowledge and experience. And it will make a lot of us better surgeons, better hernia surgeons. And thank you very much, Professor Bittner, for accepting our invitation in one mail. I know you are a very busy surgeon. Now you have difficult times. Also, you have the second lockdown. But in spite of everything, you agreed to come overboard and deliver this talk. And this talk was very, very enlightening, because we have been talking about the retrorectus repair, and you have given this hybrid approach, which was very, very innovative and very, very useful. And I think many of us in India are going to follow what you've shown today and help our patients recover better. Professor Chobe, sir, thank you very much. You are, as I always say, you're always a phone call away, and there is never a no from you. You're always there for teaching and training and leadership. And all of us look up to you throughout India and throughout the world for your leadership. And you always, in spite of your such a busy schedule, you give the impression that you're always available. And we are very, very grateful and privileged to have you with us. And Dr. S.P. Dev Sarkar, who is from Calcutta. He is now the treasurer of Indian Association of Gastrointestinal Endosurgeons, and he has held many positions in the Indian Association of Gastrointestinal Surgery. He's a prolific surgeon, very good teacher, does a lot of endoscopic surgeries, and in the eastern part of India, he's supposed to be an endoscopic wizard. And he started training programs in medical colleges, and I don't know where Satyapriyo gets all his energy, and he still has a smile on his face after the end of the hard day. And Pallavi, thank you very much for organizing and always being there. I keep on bothering her with small details, but she always has this beautiful smile on her face and always willing. And the way she organizes, I'm very, very impressed, Pallavi. The way you speak, the way you organize, and the way you look at small details, that is very, very impressive. So thank you very much, Pallavi. And thank you very much, Docplexus, for being a part of Hernia Society throughout this pandemic. And as Pallavi said, we've had a lot of programs which were very well attended. And I'm grateful to all of you all for this excellent meeting. Thank you very much, Professor Bittner, Sir, Pradeep Chaubey, Satyapriya, Pallavi, and Docplexus. Good evening and good night.
Good night.
Thank you very much. Thank you very much. Thank you. Thank you. Privilege. Thank you.